Hi, welcome to Medical Update. I'm your host, Dr. Mike Rosen. In 2010, the National Cancer Institute announced that almost 70,000 new melanoma cases were diagnosed in the U.S. and almost 9,000 people died from the disease. While melanoma is the least common form of skin cancer, it is considered the most serious and the most deadly. With us to discuss the ways to prevent skin cancer is Dr. Michele Green, a top dermatologist at Lenox Hill Hospital in Manhattan. Welcome to Medical Update.
Hi, thank you for having me.
You know, this is a little depressing because I love the sun, and cases are on the rise. And is this sort of the message that we should just be hiding from the sun completely?
Well, you don't have to hide completely from the sun, but you should protect yourself during the key hours from the sun, meaning from 10 in the morning till 4 in the afternoon. You should try your best.
Which is only like the whole day.
Yeah, well, you should try your best to wear a hat and good UVA and UVB protection, and to really protect yourself well against the dangers of the sun.
So it's not just a matter of if you're laying out, if you're going out, if you're going to work, if you're walking in the park.
That's right.
You're saying we should be really acting as if we're at the beach.
That's right. All day long you're exposed to UVA and UVB rays, and they both can cause skin cancer.
I mean, I have to confess, I don't carry around sunscreen in my briefcase or in my pocket, and if I'm going out to the ball game for the day, I don't put sunscreen on. What percentage of people really do that?
I think a fair number now are starting to use sunscreen. I tell patients the way you brush your teeth in the morning, after you brush your teeth, put sunscreen on. It's that simple. You know, if you're going to be out for an extended period of time, you should be wearing a hat at the ball game, not just sunscreen.
Why do you wear a hat? Is it to cover the face, or is it to cover the skin on the head, or both?
Both. The face and the areas that are really exposed most to the sun, meaning your face, your scalp, your arms, your hands, are the most common areas that people get skin cancer. So those are the key areas to protect. So a hat will protect your face. The nose on your face is the most common area of the face to get a skin cancer because it's sticking out and it's being exposed most to the sun. So
when you see all the people at the beach,
I cringe.
Do you?
I cringe when I see people laying out and frying, wearing, you know, some people probably aren't even wearing any sun protection. If they put on it, you know, an SPF 6, I consider that no sun protection. And they're lying out and they're baking, they're frying, and I cringe because I know what lies in their future. You
really think that these people, as they move on in life, at very least they're going to get wrinkled. But Absolutely. You're worried about their health.
Absolutely. The studies show that just one sunburn alone increases your risk for melanoma by 50%. That's just one sunburn. So, you know, just do the math. If you've had 20 sunburns, you're at a much higher risk. And now the statistics show that every 62 minutes, that's almost once an hour, there's a new patient dying of melanoma.
But in terms of prevention, and you're talking about sunscreen,
right.
Really, what should we be doing? Well, so you talked about wearing a hat.
Right, wearing a hat.
Covering yourself in armor.
Staying out.
But if you don't cover yourself in armor.
Staying out during those key hours of the day and putting on at least 1 ounce of sunscreen 30 minutes before you go outside. What people don't understand is they put a little bit of sunscreen on and they think that's sufficient. You have to use 1 fluid ounce. That's a lot of sunscreen.
It's expensive stuff.
Well, it's a lot less expensive than getting skin cancer.
So does it matter which brand? Does it matter? What should we be looking for on the labels?
Okay, I think that's a great question. I don't think the brand is as important as what the new labels. There are new FDA regulations coming down in the spring. And what will happen is there won't be as much confusion as there is now. The labels will say the maximum will be SPF 50 on any given label. And it will also say whether or not it protects against UVA and UVB. In order for a new sunscreen to say that it has broad spectrum protection, it has to have a higher number than SPF 15 and also be able to show that it protects against UVA and UVB radiation.
The American Academy of Dermatology formally has recommended really SPF of 15 as the number. So what you're saying is 50 is...
50 is the maximum that will be allowed to be printed on any tube. 15 is probably the lowest number that's considered acceptable. In other words, numbers like 6 and 7 or 8 won't be allowed to say that they protect you against skin cancer, won't be able to say that they protect you against wrinkles or photoaging, because they don't.
But there's not really much of a difference between a 15 and 50 because there's a curve, and you sort of get up to the top of the curve, and the amount that you get from a 15 to a 50 is...
Well, you know, but they'll show on the sunscreen itself how long your sunscreen is going to last for. So I think that's going to be the most important thing. They're going to tell you on the actual tube if it will last for 20 minutes, an hour, when you have to reapply it. And I think that's really important information because people make the mistake commonly. They put on the sunscreen and they go out and then they think they don't have to reapply it, and it's really important to reapply it. And I think people are lulled into a false sense of security that they put on the sunscreen once during the day, or maybe even twice, and they think, oh, they're all set. But now if a tube actually says you need to reapply it after 40 minutes, I think people's understanding of how long the sunscreen really lasts will be much clearer to people.
It actually gets broken down in the skin.
That's right.
So it becomes less effective.
That's right.
And if you get wet...
If you get wet, it comes off. It will, I mean, the new...
But isn't it rubbed into the skin?
And rubbed right out from the water. What's really a great thing that the FDA regulations are going to show is that the new sunscreens will say water-resistant only. They're not going to be able to say sweat-proof, waterproof, because there is no such thing as waterproof. There is no such thing as sweat-proof. And the new water-resistant sunscreens will only have 2 times, 40 minutes and 80 minutes. That's the maximum that a sunscreen will last on you.
And what if you're a person who does sweat? Especially if you're laying in the hot sun, you're sweating.
That's right. You're going to have to reapply it for it to be effective.
But can you reapply on sweaty skin? I mean, I'm talking about...
Sure. Practically speaking, you probably have to...
You towel
off and reapply the sunscreen.
But you shouldn't be laying in the sun in the first place.
It's a lot of work, right?
It is a lot of work. Okay. So now that we've covered the sunscreen, in terms of preventative screening, in terms of going to the dermatologist, should we be going to a dermatologist? Can we go to a primary care doctor? Who should be looking at us once a year, once a lifetime, never?
That's a great question. Internists are wonderful at referring to dermatologists, but they only get 1 week of dermatology training during the course of their entire residency. 1 week. So they're really not skilled in being able to differentiate between a skin cancer and a benign lesion. So a dermatologist goes for residency for 3 years, and they're the ones who are trained in that field. And you should be going to a dermatologist, and it should be at least once a year, except if there's a family history. If there's a family history of skin cancer, if your mom or your dad or your brother or sister has had melanoma, you should be going twice a year to get screened for skin cancer.
What if you've had 5, 10 burns? I mean, is screening twice a year reasonable?
If you've had 5 or 10 burns and you've never had any skin cancer, then probably once a year is sufficient. But once you get your first skin cancer, then you're obligated to go at least twice a year.
Is that starting at age 18? Like, what would you recommend the average person out there?
I honestly, if I see a family history of melanoma, I have had children who've had melanoma, who've had skin cancer. If there's a family history of melanoma, I've had pediatricians send skin cancer patients to be examined. I would start as a child because there are children, teenagers. The number one cancer in women ages 20 to 25 is actually melanoma. It's a leading cause of death, actually, in that age group, except for accidents.
But can't you look in the mirror and say, oh, that looks kind of new? You really need a professional to do that?
Well, it's good if you notice something new, but what happens is someone has a mole for a while, and they don't notice that it's changing. They don't really understand that it's bad, and often people come in. I've had many young patients come in for acne, and I always make the patients do a skin check, a full-body skin check on the first exam, and when I ask them about a mole that's been there, they say, oh, I'm not worried. It's been there forever. I'm not worried. And they're shocked when I biopsy it and tell them it's melanoma.
Wow.
So I think people don't really understand. And also there are places that people don't see. I've had many patients who have had melanoma on their backs or their buttocks, or men have them on the top of their scalp.
Does it go where the sun don't shine?
It goes where the sun don't shine because it's genetic. Obviously there's sun relation to it, so the skin cancer is exacerbated by the sun, and melanoma is exacerbated by burns, but it is genetic. Melanoma is clearly a genetic disease. So absolutely, it goes where the sun don't shine.
Can dark-skinned individuals like African Americans get it?
Absolutely. Dark-skinned individuals get it. It's more prevalent in white or Caucasian. The lighter the skin type, it goes by eye color and skin color. So the lighter the eye color, blue and green eyes, and the lighter the skin color, the more susceptible you are to burning and the more susceptible you are to getting skin cancer. But sure, there are darker patients from Brazil and Argentina and South America and Hispanic patients who get skin cancer.
About 3 minutes. Let's take a look at some pictures.
Okay, great.
And scare the audience a little bit into wearing their sunscreen. So Go through this. We have an image of a keratoacanthoma.
Okay, this is a common skin lesion that comes up very quickly, but it is a form of a squamous cell carcinoma. And patients come in, they complain that they have a new growth. They don't know, what it is. It grows very, very quickly, and this needs to be surgically removed in order to cure.
Okay. Next thing we think we have is a dysplastic nevus.
A dysplastic nevus is a very, very common mole, and I think it's an important mole to speak about because it looks very similar to a melanoma. A dysplastic nevus is really a marker to someone being more predisposed to getting a melanoma. Itself is not considered a malignant mole, but it's really just a sign that you're more predisposed than the regular person to having a malignant melanoma. And the more dysplastic nevi you have, as in this case, where someone actually has something called the familial dysplastic nevus syndrome, where they have multiple dysplastic nevi, the more dysplastic nevi have, the increased risk you have of getting a malignant melanoma during your lifetime.
Let's move to the next picture, which is
a malignant melanoma. And this was an early lesion, and it shows the variegation of color, the asymmetry, the irregular border, and the diameter of greater than 6 millimeters. There's the A, B, C, Ds of melanoma, and that's what this slide shows. The only thing I don't like about this slide is the D, the diameter greater than 6 millimeters, because a lot of melanomas start smaller, and the melanomas that we're finding nowadays are smaller than 6 millimeters.
But that's good news.
That's great news, because the cure rate is much higher, because a thin melanoma is a 99% cure rate. A thicker melanoma that's been there for a long time is only a 15% cure rate. So really, truly, people are dying from these skin cancers when they're not detected early.
Now we're moving into a different kind of skin cancer, which is basal cell carcinoma.
Right. This is a picture of a nodular basal cell carcinoma, and you can see it's a pearly papule with these red little telangiectasias that run through it, and this is the most common form of skin cancer that people present with. I think there are something like 3 million cases diagnosed each year of basal cell carcinoma.
They're not as deadly, they're easier to pick up.
That's right. And
but you do want to remove them.
That's right. And here's one on the nose, and this one is, they generally don't metastasize. That's right, they're not deadly, but they can be very cosmetically disfiguring when you get them, especially on the nose and the face, which are the primary areas, because again, it's in sun-exposed areas.
And here's an actinic keratosis.
Right. This actinic keratosis is a precancer, and 10% of these precancers go on to become squamous cell carcinomas, which can metastasize, and are potentially deadly.
Which is the next image on the screen. If we can quickly show a squamous cell carcinoma.
Squamous cell carcinoma in this man's forehead shows that that's been there for many years. It's very deep, probably because it's been there for so long. And again, between 2 and 10% of these metastasize, which are potentially fatal.
Protect your skin.
That's right.
Stay out of the sun.
Enjoy the sun, but be sun safe.
And use sunscreen.
That's right, and a lot of it.
And a lot of it. Dr. Green, thanks so much for joining us.
Thank you very much.
We'll be right back after this break.
I think someone at my friend's school has this thing called autism. My friend's brother's son has autism. My neighbor's son has autism. My son has autism.
Autism is getting closer to home. Today, 1 in 110 children is diagnosed with autism. That's a 600% increase in the last 20 years. Learn the signs at autismspeaks.org.
Welcome back to Medical Update. I'm your host, Dr. Mike Rosen. According to the American Cancer Society, prostate cancer is the most common cancer among American men and the second leading cause of cancer deaths in men. Recently, several cancer organizations have changed their early detection guidelines and recommendations concerning biopsies to help us understand PSA levels, screening changes, and the best treatment options are Dr. Louis Cavuzzi, Chairman of the Urology Department at North Shore LIJ's the Arthur Smith Institute for Urology, and Dr. Louis Potters, Chairman of Radiation Medicine for the health system. Both experts are deeply involved with North Shore LIJ's Center for Prostate Cancer, the only Long Island center dedicated to prostate cancer patients. Welcome. Thank you for joining us. Good selection of tie.
Thank you, Dr. Rosen.
I got the memo. Very good. We're talking about prostate cancer today. I'm going to throw you a curveball.
Okay.
We were joking in the green room before that this is my show, so it's all about me.
It is about you.
Yeah. But I'm going to use me as an example.
Okay.
I'm not 29. I'm a little bit older. My father has been diagnosed with prostate cancer, high-grade tumor. I'm healthy, but I'm getting towards that age, and so you can use this kind of patient because there's a lot of people like me out there who are trying to make a decision when their PSA levels start to rise. So keeping me in mind, I'm looking for some free medical care now during this show. Let's talk about what my approach is when my PSA goes up to 3 and then up to 4. What am I going to do for myself? Because I enjoy continence, I enjoy being able to be sexual, and those are the big concerns for men out there, are they not?
They are. Do you want to start, Louis?
Yeah, I think the first question is, are you getting your PSA taken? And when should you get your PSA taken? And how old are you relative to
That's my question to you.
And I think that it still remains debatable, but for somebody like yourself now whose father already has prostate cancer, the discussion is perhaps at age 40, 45 to have your first PSA. And perhaps to screen every 2 or 3 years. For a male...
Every 2 to 3 years.
Right, and then after you're over 50, then maybe screen it more frequently. If your father, or there's no family history of prostate cancer, then you can wait comfortably, I think at least until the age of 50, to start your PSA.
So prostate cancer is the most common cancer, and I'm going to put cancer in quotes, because as you know, cancer is not cancer is not cancer. No. And people may be familiar with basal cell cancers that occur on the skin, which are these little cancers that can be taken off there, have a very benign type of a course to taken care of early. Prostate cancer is similar. The majority of prostate cancers will not affect a man's life. The majority of prostate cancers will not shorten a man's life. If you take 100 men who get hit by a bus at the age of 90, and you take out their prostates, 90% will have prostate cancer. 90%. They didn't die from it, but they had it. Now, our problem as physicians are trying to tease out those people who have prostate cancer which will be clinically significant, which will affect their life at some point in time, versus those that really don't need treatment. But that's what it is now. In your case,
but we've got stats up on the screen. Let's look at those stats up on the screen.
Okay.
So if we can throw them up there. People still die from this stuff, though.
Correct. Yes.
There's 30,000 deaths each year.
Absolutely.
And maybe some of those folks who don't have a family history of prostate cancer didn't know about their prostate cancer history because their father died of coronary disease because he smoked.
The issue isn't the 30,000 deaths. There have been 30,000 men dying every year for prostate cancer for the last 15 to 20 years. The incidence of prostate cancer at about 230,000 a year now has been steadily going up. So there's a disconnect between the diagnosis of prostate cancer and those 30,000 men who have aggressive prostate cancer who need a different type of treatment. So the issue of screening, diagnosis of prostate cancer, and then teasing out those that are diagnosed with a disease that's going to potentially impact and affect their longevity is what's most important.
What about the average guy out there who has no family history?
Right.
How often should he be getting screened, and what does screening entail? It entails that blood test, the PSA, which you'll tell me about.
Screening is 2 things. Now, one, seeing your doctor and getting a rectal examination, and we'll cut to the slides to show you how they do that. And that's why the doctors are in the military. They stick a finger in the rectum. It's because you can actually feel the backside of the prostate. And the prostate is, in a young man, a walnut-sized organ that is right underneath the bladder. So the bladder is in the lower part of the belly. When you urinate, the urine comes out your urethra, the tube that brings it out through your penis. And sitting around that tube like a donut is this prostate, this walnut-sized organ. Its purpose in life is to create secretions, food for sperm to live for reproduction in order to have children. And to examine it, again, you put a finger in the rectum. It sits right on top of the rectum. You can feel the backside of it. So that's number one. And number two, going to the next slide, is in terms of diagnosis, is the blood test, the PSA blood test. And PSA ranges. It's not an absolute number. It changes as we age. As we age, the prostate gets larger, so your PSA level will go up just from having an enlarged prostate. And so the ranges are a little bit higher as you go up. But those are the 2 ways you get screened. In terms of screening, as Dr. Potter said, in about 5 years from now when you're finally 40 years old, then at that point in time, you should get a PSA done, you should get your rectal examination done, and then every 2 to 3 years, for people without a family history, it's recommended that at the age of 50, you get the PSA done and then checked every couple of years with the blood test and with the rectal examination. The other side of it, which people don't like to hear, at the age of 75 or so, they say you should stop checking PSAs. Again, for the reason we said earlier, that prostate cancer is so prevalent as we get older, but will not affect someone's life. If it is found when you are much older, there is an even smaller likelihood it will affect you long term.
Is that what you would do for yourself or your family members?
Oh,
Yes.
Yes?
Yeah.
Okay.
It's also important to recognize and understand that PSA is normal. I have PSA. The three of us sitting here have PSA. The cameraman has PSA. And there's always going to be some that leaks into the blood. It's normal. The absolute value is predicated on the size of someone's prostate, what their age is, and whether or not there's some other conditions of the prostate. You can have infections of the prostate, prostatitis, that increases. And so what's important is not any one particular single value of PSA, but what the trends in the PSA are. So that's sometimes referred to as PSA velocity, or the change in the PSA over time.
How quickly it goes up.
Right.
And so you have a person who has an elevated PSA, do the biopsies, you find a prostate cancer. Now what do you do?
90% of men who are diagnosed with prostate cancer have what we would call organ-confined disease. The disease is not spread from beyond the prostate, but you need to prove that. So some men, we may do some x-rays on or bone scans, but again, looking at what we call the pathologic risk, the way that the cells look, we can classify men into different risk categories of organ-confined disease. Those that have low-risk disease, intermediate, and high-risk disease. In all likelihood, men who have low and intermediate risk disease do not have disease that's gone beyond the prostate, and you don't really need to do the x-ray tests. In men who have high-risk disease, you'll do a CAT scan, maybe a bone scan, maybe an MRI test to make sure that the disease is confined to the prostate. If the disease is outside of the prostate in a high-risk patient, then that will lend toward a certain type of treatment that may be more systemic. Use of hormone therapy, chemotherapy, things along those lines. But for the vast majority of men diagnosed with prostate cancer, most of them have low intermediate disease that's confined, and then we have to talk about what may be best for them.
So that's presuming that we're doing the screening, someone like myself, we find the cancer, it's confined to the prostate, so it hasn't spread. Okay, let's say it's intermediate, because we have that information up on the screen. Let's say it's an intermediate risk. Now what are the different options for myself, and the risks and the benefits?
I think for intermediate risk disease, in a patient who has few comorbidities, other medical illnesses that potentially impact on their life expectancy, is a patient who requires treatment for prostate cancer. And then the options regarding treatment are surgery or perhaps radiation. Different types of surgery, there are different types of radiation therapy.
How do you make the decision which way to go? Because someone here cuts, someone here radiates.
It is based upon essentially risk tolerance of the patient. So let's make an assumption for most of these patients with localized cancer, the long-term cure rates are the same. Okay, let's say studies have shown be the radiation by the various means, surgery by the various means are, but they have different potential side effect profiles. And there are certain people who psychologically want to know what's out, want someone to look under the microscope and make sure, and then they'll elect for surgery. There are other individuals who said, absolutely in no circumstance do I want a cut on my body, and they will opt for radiation. The problem with prostate cancer is that there are choices, and some individuals have a difficult time picking which direction to go. And again, want to back up just a little bit on intermediate, maybe not, but on low-grade disease, which are a low-risk disease, which is the majority of them. Active surveillance, watching, is a very, very, very good option, because there are studies that show you have to treat about 1 in 42 men are treated to save 1 life. So that means 41 people are having either radiation or surgery who maybe it wouldn't have affected their long-term outcome. It's not going to change the natural history in terms of them being okay.
But if you're that one guy...
Correct.
And
this is America.
And if you're worrying that you're going to be that one guy...
Right.
I mean, that's why people have executive physicals and get whole-body CT scans, because they're worried that they've got something going on in their body.
And if you're that guy, then you're going to elect treatment. So observation or active surveillance is not for everybody. But I think that with appropriate management, which means we're actively managing patients with a diagnosis of low-risk disease. We're doing digital exams, we're doing PSAs, we're doing repeat biopsies to see if the disease is progressing. If you can buy 6 months of potency, if you can buy 6 months of your lifestyle as it exists today without either radiation or surgery, and the disease turns out to declare itself, A, you don't lose anything in terms of prognosis, and you've gained 6 months. If you gain 2 years, if you gain 4 years before the disease declares itself as something that requires management, then that's time that you can't get back.
Right. And the technology is changing too.
Right.
There are things that we're doing today we weren't doing 4 or 5 years ago, and we don't know what technology will be out there 4 or 5 years from now. So if we could stave off treatment, then we may even have less invasive treatment down the road. So it makes sense for some patients, you're right.
Big take-home points that you would want to bring out that we didn't touch on.
So we know that patients make decisions based on anecdotes. Your golf buddy, the guy down the street, your wife's husband, or your wife's friend's husband, you know, whatever. And so it's important to take the time to be educated about what the options are and to try and eliminate the distractions of the internet and the mass market that has a lot of things to sell about prostate cancer.
I hope you said what you wanted to say because we're out of time.
Exactly.
But thank you so much for coming.
Thank you so much, Dr.
Great. Massive amount of information. And thank you. We'll see you next time.